Welcome to EADV Live. Today's topic, everything you wanted to know about BXT and fillers, but were afraid to ask. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have questions or comments about the subject matter, post them in the comment section at any time during the presentation, and our presenters will do their best to address them at the end. Today, we are joined by Professor Christopher Rowland Payne and Professor Ines Verner. Professor Rowland Payne is currently a consultant dermatologist to the London Clinic in London, England. And without further ado, I hand it over to him.
Thank you very much, Christopher, and thank you to the EADV, and thank you to my friend and colleague Ines Verner from Tel Aviv, with whom I've worked many, many years. And so we thought that it might be interesting to have a question and answer type of question session, so that here we are, here wanting to answer your questions on Botox and fillers. So you think of those things that you didn't want to stand up in a conference and ask, because you don't have to. You can put it anonymously on the feed here. Let us know what you want to know, some simple questions or some complicated ones. We will be very happy to try our best to answer these for you. So first of all, just to get you started, Ines is going to just give us a little tiny bit here. Ines is the president of the European Society for Cosmetic and Aesthetic Dermatology, and has been president of the Israeli Society also. And she knows very many things about Botox and fillers, and she will be just giving us a little intro here. And thank you very much, Ines.
Yes. Hello, everybody. We're honored to be here. I'm past president of the ESCAD. So let me just share my screen, or yeah. So just a second.
We can do this for you, Ines. We've got the screen here
just
for you.
go to the part where
that one.
Yes.
Go to that one.
So we can actually talk about what's happening in our field, in the aesthetic cosmetic dermatology field. And we've seen actually a huge rise of non-invasive procedures over the years. And actually, next slide, this year was really tough because we've been in lockdown, all of us. Our clinics were closed. We didn't know what's going to happen, actually. But what was interesting is that during the times that we could open the clinics, actually a lot of patients came. And this is very interesting because this is called the Zoom boom. And as a lot of people are on the Zoom, they see themselves on the video, and we were discussing this. So they complain of how they look, because all these people who are not so used to Instagram, also the older generation, people about 40 who don't see themselves usually on video, actually see themselves now, and they complain of the big nose, of the glabella, of the forehead wrinkles, all the skin texture, the pigmentation, the double chins, the sagging. So they really come and they say, listen, Dr. Verner, I can't look at myself on Zoom. I hate myself. And so they really want to have treatment. And I think this is also a new population, but also, of course, our aesthetic patients that come with this Zoom anxiety. So can you have the next one? And the other issue that also we had, and we've been actually seeing it a lot in the clinic, is that patients come in and they ask about the delayed inflammatory reactions to fillers that might be to the vaccination, to the COVID-19 vaccination. And this was due to the fact that during the Moderna vaccine trial, which had a little bit more than 15,000 patients, there were actually 3 patients who had swelling after the vaccination. And so what we have seen here in Israel is that we already have nearly 5 million who had just 1 dose, and another 3.8 who have received 2 doses. And we've had a few cases of swelling and some redness. The good thing is is that all these cases actually subsided. So the swelling and the redness subsided very fast, just after a few days. Sometimes prednisone was needed, but also for just 2 or 3 days to assist. So we can actually quite reassure our patients regarding this. So let's go to the next topic. What questions did we have, Chris? Was there?
So the first question we've got is there's a question come in asking about the gummy smile and what would you do for the gummy smile, B9? And so the question is, dear doctors, can you please tell me what you would do for the gummy smile? So I'm going to ask Ines to give us an idea of what you think, first of all, Ines.
Yes. So actually, the gummy smile is a very good indication and also something that we do see. Most of the patients are referred to us by dentists, actually, because we're the ones who can treat it by botulinum toxin. And I can show you how I do it. We can later discuss. Maybe, Chris, you can also tell us how you approach this, because there are many different approaches for this problem, which is quite common. And also, when you see the gummy smile, you can actually propose it to your patient just as an add-on, because the quantity of botulinum toxin that you need there is really very minor. So maybe next slide. So actually, what is also very important to understand is that there are 3 types of gummy smile. And the one that we can use, the one that we can treat with botulinum toxin, is the medial gummy smile. Is actually the one that mainly takes the medial part of the mouth. The one that is mainly lateral is not a good indication for the botulinum toxin. So next one. And so actually, as we said, it's the excessive gingival display when people are smiling, and exposure of around 2 millimeters. This is actually how you diagnose it. The next one. And what we'd like to do is actually treat 2 muscles, because 2 muscles are involved in this gummy smile. The first one is the levator labii superioris alequanasi, which you can actually see. This is the medial one that you see on the picture here. I can't do my pointer. And the second one is the levator labii superioris. So actually, by treating
one is
this,
here, showing here, and showing here.
Yes, exactly. So
these are the snarl muscles. So I say to the patient, snarl like a dog. And then the upper lip goes up in the paramedian part. And that corresponds to these 2 muscles. Would you agree, Ines?
Yes, yes. And so by actually treating these muscles, and there are several points and several injection points which we can use, and I will show you how I do it. Actually, we can improve this problem. Next slide. So here, actually, you can see, and also here you can see the points. So I actually draw a line from the medial canthus and just go down, and I go yes, and if you go down to where the point is, Chris, with your pointer, so that's somewhere in the middle. So in the middle, around 1 centimeter above the alanasi, I will inject. You can also go a little bit lower, but this is mostly the main point where I do most of my botulinum toxin, and I can do some.
Do you do it by?
Next one?
Do you do it by mapping, by taking a measurement, or do you do it by palpation?
Yes, you can palpate just when the patients are doing the movement that you do it again.
Yes.
Yes, then you can actually, you can actually palpate the muscle. Exactly.
And I put my finger here. I can feel it under there.
Yeah.
The point of maximum movement. That's how I choose the spot.
Yeah, and that's a very good location, because for to put in the botulinum toxin. And next one. Another point is for people, mostly it's also there's another point to do it, and that would be on the orbicularis oris. For those people who have quite a very short upper lip, you could actually do also another point just on the orbicularis oculis. Will also drop the upper lip a little bit, but the main point is where we've just shown. So next one. So this is regarding the new units and distances. And can you go on? So as we said, just to measure the gingival display, and you treat where we've pointed out, you can also do another point just a little bit more lateral to that point to get the second muscle, and that always mostly actually is very, very efficient. And patients are actually quite happy. Mostly it's younger patients who come, and they're really very, very satisfied, mostly with the results. So,
and of course, in the long run, time will get rid of their gummy smile, won't it?
Yeah, sure. And also, I think what I've seen is that people do it a few times, and the distance between the treatment is getting longer, because actually it's quite a small muscle. So it's not like the botulinum toxin we do on the forehead. Every time they come, it's getting a little better, and the spacing of the treatments is longer. And sometimes after a few years, you really don't need to do it anymore. So that's also something that happens here, just as with the masseter, which we treat also for masseter hypertrophy. Also, with time, there is kind of an improvement on the long run. So let's go on to the next one. So this was just also an example. This was a very nice publication. You can take the reference and go to the next one, also showing some nice results, really, which is really an improvement after the treatment. So next. So let's see. What is the other another question that we had?
The question that's just come in is, what do you mean by units? And this is an old chestnut, so we have a slide ready to tell you about B naught. We have a slide here that will tell us the difference in the different units. This slide tells you the difference between the different units. So one neurotoxin unit is the same as one allergan unit, which is the same as one Mertz unit, which is the same as 2.5 Spaywood units, broadly speaking. So in other words, 2.5 Dysport is the same as one Botox, broadly speaking. Would you agree with that?
Yeah, I do.
And so you do need to, of course, make sure you're talking about the right units. So in all the slides I'm going to show, they're all neurotoxin units. So then you'll know that it's 2.5 Spaywood or one Botox.
Mm-hmm. Yeah, and I think,
go ahead.
No, what I was wanted to say is that it's very, very important to get one formulation and to use it all over, to get used to the volumes and the units when you're a beginner, not to mix too much, because somehow you really need to have kind of a feel for the amount that you need in each area. And with the years, that's what's happening. You just do it intuitively. So I have to say that after all these years, I don't calculate the units anymore. I just intuitively, automatically inject.
Yes. I'm thinking more in terms of volume, because I know how powerful the stuff is, because I always dilute at the same concentration.
Yeah, exactly. So really, we will look at the volume, and yeah, me too. And not every time I calculate. So yeah, exactly.
So we've had a question here about what happens if you inject too much filler. What should you do if you inject too much filler? So you can go back to the pictures of the two speakers. Thanks. And then we'll find some slides that answer this question. So of course, everybody sees a patient now and again who seems to have had too much filler. I like to say that I keep the keep this stuff ready, these tricks ready in the background. The first thing to do, I would say, is don't reach straight away for hyaluronidase, because it's a blunt instrument. If it is near the surface, like you can see on this slide here, you can see that there's some Tyndall effect in the nasolabial groove. Or in this one, you can see some little tiny bumps just at the angle of the mouth. Just here, you can see some little dots just here. These little dots are some filler that is finding its way towards the surface, rather bluish looking dots. And if you can incise and drain these, then that's better. So here I've made some little puncture wounds, and I squeeze, and then out comes the stuff. So we can squeeze out. And this is a very useful trick on the neck. Some people might have done some little tiny papules in a neck groove, and then you regret because they're a little bit too superficial, and they may look a little bluish bumps. You don't need to inject hyaluronidase. Just a little nick, squeeze them out. Very simple. But
yeah, it's very...
Yeah, go ahead, Ines.
No, this is very interesting because these dots in the angle of the mouth is something that we see in people who are returning clients. And actually, I think this is something that we see when after multiple injections in this area. And so it's interesting because I think all of us have the patients that have it. And it's a very interesting technique what you showed, because, yeah.
And I think what happens is if you've had filler for a long time underneath the skin, it finds its way up towards the surface. And so you see that very much in the infraorbital skin. Sometimes people who have, I always like to say they've been unfaithful and gone to Los Angeles for some injections, and they come back, and then we have a different optic in London, and say we may want to remove a little bit of the excess enthusiasm. And so, of course, here is a Tyndall effect in the infraorbital skin, where you can see the skin, and here again, an even clearer one. And these take some months or even years to develop. So the filler can be put in just the right place and produce a beautiful result, but it just gradually drawing water in, becoming, it's a hydrophilic substance, and the water stays. And in this place, there isn't much natural hyaluronidase, and the filler can stay for a long time. So sometimes you do need to use some hyaluronidase. And so this is the stuff. And every dermatologist who does filler injections needs to keep this one in their office. And I find a useful dilution for these non-urgent cases is to dilute 1 ampoule in 7.5 mLs, which gives you 2 international units. The calculation is easy, and you can use maybe using an insulin syringe. You might use 0.1 of a mil to maybe 0.2 of a mil for that last patient that I just showed you, the one with the infraorbital, and you can see it disappear in front of your eyes, and you can come back a minute or so later, and if it isn't enough, put a little bit more in. You don't need to put a lot in. Of course, if you put too much in, you'll end up having to put filler back. And so I try to, often I'd use a cannula in an infraorbital Tyndall like that. What about you, Ines?
Well, I always have ready hyaluronidase in the fridge in the clinic. So, and yes, if there is some overcorrection at the tear trough area, and also not always it's overcorrection, it's like you said, some people develop this swelling even sometimes years after they've been injected in this area. So they can come 3 years later and they say, I have some puffiness in this area, it's swollen. What I do is I also use I use a different hyaluronidase preparation, but it also has 1,500 units in the vial, and I dilute it with 5 cc of saline, And what I do, I can even start with much less. Sometimes I start with 0.025 cc. So I take the insulin syringe, 0.3 insulin syringe, and I even do half a dot of the syringe, just a very tiny bit, and then I push the area. I just massage it, and many times it's enough because you don't
Yes.
want to dissolve the whole filler.
Yes.
You just
Yes.
want to dissolve a tiny bit, and
Yes.
just to get it to the right level. Many times I will tell my patients to come back after 2 weeks, and then we check the result, because it you know, you see the result, you actually see some working of the hyaluronidase
You can
immediately.
actually see it happen before your eyes, can't you?
Yes, which is amazing, but
Yeah.
it also continues. The effect can
Yes.
continue for a few more days.
Yes.
So this is why I let my patients come in again, and then we can do just a tiny bit more if it is needed.
Yeah, exactly.
So not to dissolve everything, because
Yes. It's very easy to put too much in of the
yes, for the
hyaluronidase, isn't it?
yes, and that has happened to me in the past. So this is why I'm very, very cautious with the quantities, especially for overcorrection. Of course, if you have an intravascular accident injection, you have to do a lot. But for the overcorrection and in the tear trough area, also the filler is not a high G prime filler, so it's a filler with not so much cross-linking. And so these fillers are dissolved mostly also very, very fast.
Yes, yes. We have a question, a Facebook question. Can we put that on the screen? Let's see what it says. Hello, Ahmed. How to depress the inner eyebrow if highly elevated in comparison to the inner eyebrow on the other side? So now that's an unusual, yes, okay, I see. So you're starting
Actually,
before treatment now. So one medial eyebrow is descended and the other is elevated. So this will be due to a differential effect of the upward pull of frontalis and the downward pull of corrugator. And so some people have I wonder if I can do it now. I can move them quite a lot, but I can't quite get exactly what I'm trying to do there.
actually, I have some slides regarding this
So which
in
number would
the
those be under?
presentation, because I think actually
B7.
this is
B7.
well, it can of course be the way it is built, but it can also be a side effect of botulinum toxin injection. And that happens actually when you inject the frontalis muscle and you inject too low. If you inject the botulinum toxin actually too low in the middle part of the frontalis, you will have a medial brow drop. And a lot of people don't inject enough or don't inject the lateral part of the frontalis because we want to have this lateral lift. So what you actually get is the Spock sign, and you can I will show you what I do, but what I mostly do for this is I don't know if I can show it on
Yes,
me, because
I've got something you prepared earlier.
so
Yeah.
yes, because I actually we had this question already online before, so I would inject just a little bit, quite high.
You can put
on the frontalis, but
the pictures
on the side.
up now, please, Christopher.
So so this is something that's very.
Can you display the slides, please, Christopher?
So actually, what you want me maybe to find those on mine?
Can you put the slides up? Or Ricardo? We don't have Schiffer's slides on the screen.
Just 1 second, I will check it with mine. I have it actually here.
Yes,
so
sure.
let me share my screen.
Schiffer to share her slides again, please.
Schiffer will share?
Yes.
Can you see Schiffer's slides?
No, we need to present again.
Okay, so can you have a private conversation with Schiffer? Can you disconnect from us?
Or just have my screen? because I have it. I can have it here.
So have you got yours there?
We will take your slides, Dr. Verner.
We can have my screen. If you can have my screen, so we can go. Can you see my slides?
Yes, we can see.
Okay, perfect. So actually, this is, I think, the most difficult part of botulinum toxin treatment is actually treating the forehead, and treating the forehead in the way that it will have the natural results, but also be effective, because people don't want to have these forehead wrinkles. So as you see, the frontalis is actually quite, a big muscle. It's very thin and it's very, very superficial. It goes from the galea aponeurotica to the forehead skin above the eyebrows. And this is actually a very good article that you should all read. It's actually published in the PRS in May 2020, and it's by our friend Sebastian Cotofana and others. And what this article actually showed is that there is actually a C-line, a convergence line in the frontalis, and this convergence line is not in the middle, it's actually around 60% above the eyebrows. And so when you treat the frontalis above the convergence line, what you see is lifting of the eyebrows. And if you treat the frontalis under this line, you actually lead to some kind of brow drop. You will always have a little bit of a drop effect when you treat this part of the frontalis. So what you have to do is, mostly in the first time the patient comes in, actually treat mainly the upper part of the frontalis, mainly the upper 40%, and only when they come, so only later, or only with very low doses, treat the lower parts of the frontalis, so that you don't have this brow drop, what you actually described. Now, a lot of people are a little bit less cautious in the medial parts of the frontalis, and a little bit more cautious on the lateral parts for the females. And so then you can get this Spock sign. So here again, actually, these are the different units. The botulinum toxin and the spaywood, so the Allergan and the spaywood units, to use, and mainly to stay really above this convergence line. So if you do too much in the center, and actually this is what we can see here, is that there is too much botulinum toxin on the central frontalis, and then there is, of course, a compensatory hyperactivation, exaggeration of the wrinkles for the lateral frontalis. And this is really a botulinum toxin effect, and actually this is the Spock sign, as is very well known. Now, if you want to get this down, you have to put some botulinum toxin where you see this contraction. So here, for instance, where you see the contraction on the upper part of it, that's where I will put like 1 unit of Botox, and maybe 2 units of Dysport, if I would use it. So Chris, would you like to go on to this one, or would you like to go to another question?
Try B3 here, this, because I have a comment on this, if we can show these slides at this end.
Yes, sure.
Are these slides showing? Good. Okay, so if we have a look here, frontalis is opposed by quite a lot of things, corrugator, but also orbicularis oculi and depressor supercilii, which is a tiny slip of orbicularis oculi, and procera. So all of these are pulling down. And so the natural descent also exaggerated by gravity. So you can, if the eyebrow is falling, you can put a little bit of botulinum at these places that I've marked with the black dot. But these are very small doses. You don't want to come over the middle of the mid-pupillary line, because you risk touching levator palpebris superioris, which would then result in a ptosis of the eyelid, which you want to avoid at all costs. But if you put a little bit of botulinum in these places, and I'm talking here about a unit or two of dysport, so that's a fraction of a botulinum unit, and then you can get some elevation. So here we're putting half a neurotoxin unit at each of these points. That's half a Botox unit at each of those points. That would be a way of raising the eyebrow. And eyebrow ptosis it's something really that is waiting for all of us because of these four muscles. And in that femme fatale, the look that you have for Spock, and we can correct this to the normal control versus the femme fatale look. We can correct this, just as Ines was saying, with botulinum, a little tiny bit at the tail and a tiny bit at the medial end. Now, those 2 points at the medial end, I do in almost every patient I see, because you can see in the pictures that you showed of the famous actress in the last slide, your slides, not Marlene Dietrich, but the current one from Australia. You showed, now if 2 dots of botulinum were put at the medial end of the eyebrow, it would rise, and then there would be a more horizontal type of shape. Thank you. So now next we've got to, let me see with a question here. How would you compensate for the Spock sign? Well, we've said that. And then how would you recommend a brow lift with botulinum? We've done that too. Okay, so those 2 questions have been answered there. And so now we have another question coming in, and that is, should we aspirate before we do filler injections? So, then what would you say to that, Ines? Should we aspirate when we do filler injections?
Well, that's a very good question. And I think that personally, I think that in some areas you should, in some areas, for instance, in the temporal area. On the other hand, I think we move. If you're with a needle, you move, and you're you'd never know where you are, actually. So even if you aspirate and you don't get anything out, you can still be in a vessel. So I think this is, I think there's always a danger, even if you do. And maybe this can be something after you discuss what you think. I think that in the future we will have the ultrasound mapping, and I think this is something that's coming up now, and we will be able to map the vessels of our patients, especially in the areas where in the danger zones. So we will know where the temporal artery is, for instance, and how deep it is. And then you don't need to inject where it is. You can inject lateral. You can. So I think this is something that will happen.
That's we'll do that one a different one. F naught. Oh yes, that's
so.
Of course, what we're always worried about. This is the slide show now, please. Slide again. What we're always worried about is retinal artery occlusion, and so we know that this happens because of intravascular injection, and we want it all. We want to make all our efforts to try to avoid it. This is a very good paper, 2016, and so well out of date now, but the principles still apply. And the sites of filler injections in 98 patients who had retinal artery problems. So these patients all suffered in their vision, and all these different sites of injection. Of course, these are fairly, these are stylized injection points, but it does show you that there isn't really anywhere safe. It is worth noting, though, that 50% of these were fat injections and only a quarter were hyaluronic acid. And so what we can say is that fat is a much more viscous and thick substance, and so much more capable of blocking your syringe or your cannula, and also the artery that it might go into. But there are some things that, here is something that a blob of hyaluronic acid, and you can see it's bright red blood, so that's obviously arterial, and that was in the end of this syringe that I was putting somewhere in the face, I can't remember now. But aspiration meant that I didn't inject that intravascularly into an artery with some horrible consequences. So I would say that we should aspirate, but we don't always need to aspirate in every single case. It's not always necessary, because if you're moving with the needle, as Ines said, then if you inject, you will have been through the artery very quickly. Nothing will do any damage. If you have aspirated and then you're still, then you can still have a problem, but it's less likely than if you didn't aspirate. So use small amounts, try to aspirate if you can. That's probably even true with cannulas, fine cannulas of 27 gauge, for example, which I like to use. I always aspirate before I use a non-moving injection.
Yeah, I agree. And also, I personally, for instance, when I inject the nose, I would only inject with cannulas. So I think the real danger zones, sometimes it's better to inject with a cannula. And if you use a thin cannula, you really need to aspirate. And even that is not safe. So you're never 100% safe. And that's
There's
the
another
horror.
good question here. Somebody called Joseph is asking, what points, volumes, and kinds of fillers do you use for the tear trough? And do you use insulin syringes for this? So, Ines, what do you like to use in the tear trough for fillers?
So can we actually so we will say brand of a filler, right? So
well, I think, why don't you say standard, or more diluted, or more concentrated? So what we mean by that is that there are those thicker ones that you can use, the stiffer, thicker ones, which are advocated for deeper use, or there's the standard one that we all probably use most of the time, and then there are the slightly sort of thinner ones that people can use in places where.
So I can tell you what I do. I don't have any connections to any of the companies, just to say, but I will say. So first of all, I would use a low G prime filler, the lowest that you can have. Personally, I use the Tocial range, RHA1, and I will use very, very little. The maximum I will use for the tear trough will be one syringe for both sides. So and mostly I will under correct. So it's very, very important to under correct this area. So even if it's enough with 0.2 cc's, I will not inject more. It can be the quantity can be very, very small. And what you will see that after a few days, there is actually improvement in this area, because of the hydrophility of the filler, because the filler is hydrophilic, so it attracts water in this area. So actually the result will improve. Also the wrinkles in this area will get better within a few days, but it's very, very essential to undercorrect. And personally, I like to use the lowest G prime that's possible for this area. So this is from my, what is your experience? Sorry.
I agree with you. I use a very low G prime, and I very much undercorrect, but I try not to do it. I try, if possible, to fill other places, like, for example, the cheek. If you fill the cheek here, then if you fill here, then this comes up a little bit. Because don't forget that there are two parts to aging. And I've got a slide for this one.
Yeah, I agree with you completely. Sure.
There are two ways that we age in terms of the subcutaneous fat. We have half a pound of butter here. That's 250 grams for you Europeans. we have half a pound of butter here, which gradually drifts down and ends up as jowls down here. And this exposes, it falls away from the orbital rim. We get the much deeper tear trough look here. And the second thing is that the sides of the face slide forward. So let me see the picture and I can show you the second form. So the first is where it's drifting downwards. And the second, can we have the pictures now? Is gravitational descent of the face. The first is the paramedian fat descent, which I just described. And the second is where the lateral face slides forward. So you get the impression of this in Mr. Churchill here in the film recently. And if you tilt the head forward, you can see the side of the face sliding forward. Here, this patient, the side of the face sliding forward and being retained at this point by the ligament, but the rest of this is all sliding forward. So
and also there is this movement like a book that's closing down. So it's very, very important, like you said, to open up the central part of the face, and then you actually also get a lot of improvement in the tear trough. Yes, of course, if you see the area around and you treat it, it will improve.
One of the things that if you put some filler here, not in the tear trough, but maybe a centimeter or two inferior to it, you can get lifting, which will then obscure the tear trough in some patients. And if this is a very deep injection, pushed up along the bone, past the infraorbital foramen, slightly uncomfortable, and then you come against a resistance, which if you put your filler here in 3 or 4 little pieces underneath this, you can push up the tear trough from underneath, and that can be a useful trick without actually entering the tear trough.
Yeah, and this actually corresponds anatomically to the deep fat pad that is there, and actually once you treat it, the filler will stay there very long and will actually support this area. So it's very the smaller area will be supported by deep filler injection for the deep fat pad at that area. So what are more questions that we have? What is here? Drop.
Here are a couple of slides, which
in some cases, maybe you want to go on. What would you like? There is one coming up here.
I've got another point to say about the. Can we put these slides on again? We've got. If we put filler behind the ala nasi, we can lift the face forward. Are you online now or not? So they're just coming up now. So this is a nice trick, this one, for not having to put your fillers always directly into the tear trough. So this is a very useful technique where volume for volume, I'd say it's the best place to put your filler in the face. And so if we have the ptosis of the nasal tip, it will help to treat that also, because we've been smiling and too much, and every time we smile, we push the nose into the face and create the nasolabial grooves, and compressing the fat that lies behind the ala nasi. Think of the nose as the tent pole of the face. And so if you think this is now the nose, and then if we put filler behind the ala nasi, we can push the nose forward.
Yeah, this is very, very important.
And the place that you're going is called Risto's deep piriform fossa, which you can see beneath the ala nasi. And you can find your way in there with a cannula and restore anterior projection. And this will lift the midface. But this is how it's done. I think experience has taught me that you must do this with a cannula. So you pop through the skin and then you come up to the resistance, and you go, and then you have to pop through this as well. And there you can see the cannula advances. And then about 0.1 of a mil is enough, or perhaps a little less on each side. I aspirate also before I press the plunger. And seen from a different angle. So first of all, the needle ping, and then the cannula, and you put the cannula in and advance it until there's a resistance immediately behind, deep to the ala nasi, there's a ligament, and you have to pop through it, 1, 2, 3, pop. It's a little bit uncomfortable sometimes. And then once in the right place, aspirate, aspirate, and then inject. And so here you can see the effect where it brings forward and therefore gets rid of some shadows. But it doesn't just restore volume and restore anterior projection and lift the midface, which of course a facelift doesn't touch. It will also restore anterior projection of the nasal tip and help to get rid of the fossa crease and the you see it bringing it forward here. So and there has a knock-on effect onto the top of the cheek, so that the area which is immediately adjacent to the tear trough improves, and so there's less to do with the tear trough. So if you do this one before you get to the tear trough, you sometimes don't even need to do the tear trough.
Mm-hmm.
So now somebody has said here, do you not risk the angular artery at this site? Yes, you do risk the angular artery, but if you are using a blunt cannula and you're aspirating, then you're unlikely to be in the artery. But if you don't aspirate, or if you use a needle, then that would be more dangerous.
Yeah.
I'd advise that you use a cannula here. But there is no safe place in the face at all. And so we can't really think of safe zones. There are no such things. Everywhere is a hazardous zone. But you're quite right. The angular artery is a particularly vulnerable structure. We have to be careful.
Mm-hmm. Yeah, I agree with that. There is no safe zone. That's the terrible part.
Sorry, what's happening?
So
are these questions that are coming? I see.
Come on. So we have more questions.
Yeah,
we have a lot. Wow, so many. Wow, a lot of questions.
Which one do you fancy answering here, Ines?
Let's see. Oh, wait a minute.
Some nice comments too. That's nice of you. Thank you.
Wonderful.
How to manage Tyndall? I think we said that really with the hyaluronidase, or will help to clear that away.
Oh, I have a nice question here.
Yeah.
Which is, can you use vestibule and dysport at the same time in the same area? What do you think? I can say that I have sometimes used in different areas in the same injection, nothing happened, but I haven't used in the same point. But for instance,
is the question, can you use botulinum and filler in the same place? Is that really what?
No, and vestibule. Vestibule is the Botox.
Oh, I see. Different brand, two different brands.
Different brands of
why not? But
botulinum
it's a bit
toxin.
confusing. I suppose if you, yes, you could. There's no reason why you shouldn't use both brands. Vestibule being Botox, yeah. You don't.
Yes.
There's no reason not to. But I'd probably being dyslexic, I'd find that very confusing.
Yes. But that's something that I don't see any problem with it. So you can. Mostly, personally, I use the dysport, and I have most of it in the fridge. But if for instance, you have one is finished and you have the other one, no issue with that. Let's see.
Somebody's saying here, depth of level when injecting filler to tip of nose and technique, please. And I mean depth when injecting tip of nose with needle. I said now what we're talking here is about injecting here to lift the tip of the nose. So what do you do there, Ines?
Well, I have to say that in this area, I use the cannula.
Me too.
And I make a small hole just on the tip, and I go with mostly it will be a 25G cannula, and I go subdermally under the dermis. I actually go through the plane, and then I inject a little bit, and then after I will mold the area to get the filler where I
would
want
your
it to be.
injection points be here? Would that
Yes,
be,
a little bit from down under,
and then you
but
would slide up this way, would you? Like this?
Yes.
Yeah.
Yes, and you slide it up, but always never with a needle in this area. This is really something that I don't want to risk, because the nose is really one of the most dangerous areas for intravascular injection. So that's
Yes.
something that I personally don't do.
Yes, yes. And now, any pointers for glabella filler is a question here. Any pointers for glabella filler? So I'd like to reiterate what I said, that I think that it's terribly important to choose these points at the medial end of the eyebrow, on the inferior part. And if you look closely at eyebrow hairs, if you have a mirror in front of you, any of the listeners have a mirror. If you look at a mirror, you'll see that the eyebrow hairs in the medial third grow upwards, and in the lateral 2/3 they grow outwards. Where that point changes is the second injection. So the first injection is at the medial end of the eyebrow, inferior part. Can you see that, Ines?
Yes, yes.
And
very
then
interesting.
just a little bit further along, this is where the direction changes, and this would be where the second one is. But actually, I don't just do those blind. I palpate. I immobilize the eyebrow, and I immobilize the whole of the eyebrow here, and then I ask the patient to frown, 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 and then I can see exactly where these places are, and that's. My tip would be for glabella is don't inject according to a formula. Try to inject R20. Try to inject where you see the dimple occur, because these muscles, they don't run from A to B. They run from the bone to the skin. When they reach the skin, how are they attached to the skin? It's not magic. They're attached to the pilosebaceous orifices. So the strands of the muscle, tiny fibers, are reaching each little area. And so here, even in my 8-year-old daughter, who's now a little older, you can see here the dimples where the corrugator inserts. So for me, I would put 1 unit here, or half a unit, in each of these 4 places, as well as the 2 that I showed you underneath here. And that would be rather than following the company plan. So I could R10. What
This is
about
very
you?
nice.
What about you,
Well,
Ines?
yes, actually, I agree very much regarding this. I don't always like the injection points that we've been taught by the companies. And actually, maybe we can go, because I had this little presentation regarding the 3 versus 5 points botulinum toxin. So actually, I can discuss it shortly. There is a very nice study of a few years ago, and Bertolucciani and Benjamin Asher in the study, where they actually compared treating the glabella either by 3 points, which means 1 for the procerus,
We have a
and
slide here.
Yes, 1 for the medial corrugator, and or to do 5 points, which actually takes also the lateral parts of the corrugator muscle, the insertion of the corrugator.
Is this the slide? This is the picture of 5 versus, and where are the 3 on this picture?
So I actually, let me try to find it in mine. Show slides from my computer. Yes, here I have it. So if just a second. If you can just have my screen, then I can show it. So actually the recommendations of the companies that we had many years ago were all of them 5 points, and also the lateral parts of the corrugator, the insertion of it. And this is a very nice article, actually published already in 2006. And they gave 110 patients 3 injection points and 111 5 injection points. And what they actually saw is that the 3 central injection points are essential for the treatment of the glabella, and the 2 other injection points, the lateral ones, did not significantly improve the efficacy. And this is patient with 3 points, and this is one with 5. And this one, it's better, but it's also a bit of a younger patient. And so since then, what I actually been doing, I've been actually injecting in all patients the 3 points, and I check for the insertion, for the lateral corrugator insertion point. And if the lateral point is very prominent, then I will just inject at the insertion point a very tiny bit of botulinum toxin, not the dose that was recommended by the companies before. And if it's not prominent, then I don't even inject this point. And the results are very good. And I can even say that it gives you even more natural results to not use these points in the people who don't need it, because a lot of the people just don't need you to inject this point. So what do you think?
I quite agree with you. Don't do it if it's, can we see the slides at this end, please? Don't do the injection if it's not needed. We'll show our picture.
Yes, exactly.
This is the old-fashioned company advice. All the companies were pretty much the same. The problem here is that the middle one treats procerus quite well. The second one going outwards is too superior to treat corrugator, because corrugator runs under the eyebrow. It doesn't run 0.5 centimeter above the medial end of the eyebrow. That's where frontalis is. And the 1 centimeter above the mid-pupillary line, that's way out of range of corrugator. You're only treating frontalis. So if you do the company injections here, apart from the middle one, the other 2 will have the effect of paralyzing frontalis in its medial part. And so the eyebrow medial part will fall. And this is what we see in the picture you showed of the actress. Where
exactly.
Yeah, so if the injection points had been nearer the eyebrow or in the eyebrow or touching the eyebrow, the result would be more natural. And and these ones are all 4 neurotoxin units, or that's 10 Dysport or 4 Botox for all of these shots. And I think that's way over what I would do. So total dose here would be 20 neurotoxin units for the corrugator procerus complex, according to the standard company advice. And I say don't do that. And so what I suggest is that you feel where these are. I showed you the ones superior to the eyebrow. You could see in my daughter where the dimples are. And in each place, only 0.5 neurotoxin unit is what you're echoing what Ines says in the lateral eyebrow. And the other ones, depending on where you find them, that's why the spots are not the same on each side, which might answer the question of the earlier questioner who asked us what we do if one eyebrow medial is taller and one is shorter, and what we do. So we would do an adjustment of this according to the circumstances.
Yeah, very nice. Actually, I see another question here.
Oh, and I should also stress that these are always intradermal, these injections.
Yes, superficial. And this is actually also for the forehead. Personally, I inject superficially because the muscle is very superficial, and by superficial injection, you're much less traumatic than when you go deep. So actually, you have no bruising when you are superficial. No bruising, no trauma. Actually, we have quite a lot of interesting questions
Excellent
here.
questions here.
Excellent.
Which one do you fancy?
So let's do, what do you think? Two or so more. So I have one here saying, do you like and recommend skin boosters? So what do you think, Chris?
Say that one again, Ines. Repeat the question.
Do you like and recommend skin boosters?
Skin boosters. Yes, I think I do. What about you?
Yeah,
And
me
I
too.
realized actually long after, I didn't understand what they meant by skin boosters, because, you know, when they sold fillers, first of all, they called them dermal fillers. And then I went to all these demonstrations and I said, well, they're not doing dermal injections because there would be a white bleb. They're doing subcutaneous injections. And all the filler, it's still, they call them dermal fillers. I do sometimes put them intradermally, but tiny amount compared to what we put in the subcutaneous, especially subdermally. And so then when they brought in skin boosters, they said, well, where are they putting this magic plane? But actually, that's the plane I was using mainly anyway, because you know that there's bone and there's skin, and between them is the SMAS, and there's a superficial fat and there's a deep fat. This is a bit simplistic, but mainly the companies like you to put your injections between the bone and the SMAS, as you have to put quite a lot of stuff there in order to get an effect. And you have to put quite a lot of stuff deep here. But if you put it in the subcutaneous plane, quite small amounts will produce quite a good effect. And so that's what I've been doing mostly. But actually, this is exactly where skin boosters are put. But skin boosters are diluted hyaluronic acid with additive stuff. And so we get a nice nice little extra hydration and maybe a little more brightening of the surface of the skin.
Yeah.
But this, yeah. What do you think, Ines?
Well, yeah, I think it's nice. And actually, me personally, when they came out with this skin booster idea, I was quite skeptic. But lately, I have quite a whole group of patients, maybe mostly a bit younger patient group, that really like it, and they come even once a month or once in 2 months, and they just do such the skin booster on superficial, and really the effect on the skin texture over time is amazing. And I've had patients, younger patients of around, well, younger, 40, 50, younger, the more
they're young. They're young.
The more we advance, the younger our patients are, So between 40 and 50 are very young for us, for me. So the 40, 50 patients, sometimes they have, their texture is not so good, and then they do a few times this skin booster, and their skin really, the texture really gets much better.
And the pores improve a little bit, don't they?
Yes, and the pores, so people really like it.
Yes. So we can take one more question, I think, and then we should wrap up. So what do you fancy here on these?
Well,
somebody's asked about the depth of the Botox injection behind the ala nasi. Well, it's your once you've taken the cannula into the skin on your way to the nose, just be touching the skin all the time until and you'll find that you're in the right. So it's superficial plane.
So regarding
there's not much. Once you get in the hole behind the ala nasi, there's only one plane. That space fills everything between bone and cartilage.
But there is also a question: what about botulinum toxin in the ala nasi?
Yeah,
and
what
that's
would you say
something
about
actually.
that?
Yeah, you can. I have a few patients with dilated nares. So if they have like this big nares, and it is due to the muscle, the dilator naris. That's the name of the muscle. Dilator naris muscle. And it's actually here, just on the side of the nair. So you can inject in the middle of the nair, subdermally, or just very superficial botulinum toxin. You can do 2 botulinum toxin, or something like between something like 8 units, sometimes a little bit less. Mostly you will need the 8 units of the dye sport. And actually, it's a really nice effect to close this area a little bit. So this is a nice point. And actually,
can you point out where the injections would be if you come very close?
Oh, just in the middle, the muscle.
Yes.
There are two parts in the muscle. There is a posterior part and a medial part. It's a very small muscle. So the medial part is just here, and the muscle is longitudinal. The lateral part goes a little bit like perpendicular, like that, a little bit with an angle. So you just inject the botulinum toxin there. You don't need to be very precise because nothing can happen. The worst case, there's nothing there.
I just happen to have here a chapter I wrote on this.
Oh, really?
On medical rhinoplasty. So here's I don't know if you can see these drawings properly. If I hold them close here. If you look at this one here, this one is for nostril flaring. That one.
Yes.
That
yes. Exactly.
For nostril flaring.
So yeah.
And this one is for to treat dilator. Yeah. This is another technique here. That one.
It's a bit different from what I do, but actually very close to what I do.
This is the one for nostril flaring. Yeah, these two places. Sometimes I also put one under the nose for depressed like that. This has more points on it here. Can you see that?
Oh, very nice. Yeah, very. It's but it's very effective and just
And we can raise the nasal tip a little, can't we, like this, with these, but very tiny amounts.
Yeah, you don't need a lot. It's effective. Patients are happy.
I think then what we can do is we can say we've really enjoyed this. I know Ines, I could tell from her eyes, we've had fun talking to you guys.
Yeah.
And thank you for all the questions, and thank you to Projection. I know it's a nightmare, but my secretary, I'm particularly going to thank Shifa. Thank you, Shifa.
Yeah, Shifa, thanks
absolutely
a lot.
amazing, because she has been the linchpin here. Thank you very much, everybody. Thank you.
Yeah, thank you very much.
Thank you, Ines. It's actually been a fantastic session. People are pouring questions in, and there's so much interest. I feel that we are depriving them of more information from you guys. So if I may, in part as a chair of the education committee, I would really like to re-invite you guys maybe and pile up the questions and see if we can do a comeback session, because I feel that people have not had all the questions, and actually encourage them to ask. I've never seen so many questions coming in, so it's really great.
I think Ines and I will be very happy, but I'm just not sure about Shifa. Thank you.
Oh, yes, this was great. Yes, a lot of questions are still coming in, but so maybe next time.
We can keep them down and then have them as a base for the next one. And it would be great. Also, is a good way to liaise with your task force of cosmetic dermatology. So it's also a very important task force in EADV, and it's great to keep on training people in this field and do this properly. So thank you so much, guys.
Thank you.
Oh, you're welcome. Great. It was great. Bye-bye.
We would like to give a special thank you to our presenters, Professor Christopher Rowland Payne and Professor Ines Verner, for their wonderful presentation today. There were so many questions, we barely began to scratch the surface. On behalf of the EADV, we would like to thank you for joining us today. Now, the EADV invites you to join us every other Wednesday for EADV Live, webcasts in dermatology and venereology. Our next webcast will be on March 24th, entitled Controversies in Rosacea. Have a wonderful day.